You recording? There you go. Super. Well, welcome everyone. Can you hear me?
Yes.
Yes. Super. Welcome everyone. We have a wonderful speaker today. Dr. Prasad is a board certified rheumatologist and board certified nephrologist. I'm the rheumatologist. Board certified nephrologist who trained at UIC both for residency and fellowship. And he works at Sanderling and does a lot of telemedicine as well. So we just want to welcome Dr. Prasad, and you're go ahead. You're all set.
Great. Well, hi everybody. Thanks for inviting me here to kind of give a little talk here on acute kidney injury. Really great platform that you have here, and I think it's kind of exciting to interact with people from different parts of the country and different parts of the world. So today I was going to just spend a few slides here talking about kidney injury, predominantly in the hospital setting. And but I want to keep it very casual. And if anybody has a question during the presentation, just feel free to interject. So just a quick slide here before we talk about acute kidney injury. Sometimes it's important to take a step back and think about how we actually measure kidney. Okay. And the way we measure kidney function is predominantly with serum creatinine. Okay. In studies, they use inulin, which is a much more reliable and consistent marker of creatinine clearance because inulin is solely cleared. It's linearly related to GFR. However, it's expensive. It's not something that we can readily roll out into various labs. So we use, serum creatinine. Creatinine is a marker of protein breakdown, and so it has inherent limitations in measuring accurately assessing kidney function. And I didn't actually add this as a bullet point, but just to get a little physiology in there because nephrologists love tubular physiology. Creatinine is both filtered and secreted. So if you think back to like way back when you were in med school and residency, the kidney handles elements by either filtration, which is what we care about. Filtration is what the kidney clearance is related to, but there's also in the tubular level, secretion and reabsorption. One more statement, creatinine is also secreted. So part of the lab value of a serum creatinine is both the filtration and the secretion. We don't care about that, but it confounds the linear relationship between creatinine and GFR. So that you just kind of have to accept. That's the inherent limitation. In the setting of AKI, especially in the hospital, the bigger problem or the bigger confounding issue is that creatinine is highly affected by muscle mass. And as we all know, when you got a patient in the hospital and they've been there for a week or two or even less, muscle mass begins to quickly diminish. Also, patients who are hospitalized tend to be sick to begin with. They've got cancer, cirrhosis, heart failure, COPD. They've got diminished muscle mass. And so your creatinine will tend to overestimate the actual GFR in a patient with diminished muscle mass. The last thing is that creatinine does not accurately reflect GFR in a non-steady state. So if you're in the midst of kidney injury, in that first 24 hours, sometimes even more, the creatinine may not reflect that. So there's multiple, I think, nowadays you log into the EMR, whether it's your office, whether it's the hospital, and you immediately get this number, eGFR. Everyone sees it. And because it's in the lab reporting, you have an inherent desire to just take it at face value. It gives you a convenient number, but like everything, kidney function, creatinine, eGFR, whatever it is, needs to be interpreted based on the clinical situation. And then last bullet point there is that in a patient with kidney injury on dialysis, creatinine is readily removed by dialysis. So you can't really reliably use it to assess changes in kidney function. So some inherent limitations in the actual measurement of kidney function. Any questions on that particular point, whether it be from your office setting, from the hospital setting? I can take a quick pause if there's a question on that.
How off is the estimated GFR that we often see on typically?
Not a good answer to that question because it can be a huge range. You know, there was a study done on cirrhotic patients, an old study, and they measured serum creatinine, and then they did an inulin clearance to actually measure the GFR. And what they found was in cirrhotics, you know, a relatively normal creatinine of 1 to 1.2 sometimes could be, sometimes that patient's GFR was as low as 20 to 30%. So there can be massive swings, and a critical illness especially. You've got a patient in the ICU day after day who is losing muscle mass. Their creatinine is not changing. So something is happening at the kidney level where they're not producing as much creatinine because the muscle mass is declining. However, you're not seeing a fall in the creatinine level, which indicates, well, maybe the kidneys are not doing what they need to do. So don't have a good answer to that question because, again, it just depends on the patient.
Thank you.
Okay. So this is a case we'll come back to a few times. I know it's a little bit busy, but I tried to pack as much, you know, kidney damaging items in it as possible. And so we'll come back to it. Would it be helpful if I read it out loud and emphasize the kind of key points?
Yes.
Okay. So Mr. Kidney is 70 years old. He's got a history of diabetes for 20 years, has been on insulin for the last several. He also has hypertension. He's admitted with a lobar pneumonia. He's hypoxic. He's critically ill, moved to the ICU. His cultures are negative. You see there, he's got a low-grade temp. His blood pressure is 102/54. He's tachypnic and hypoxic. His med list is noted. He's on broad spectrum antibiotics, Vanc, Zosyn. He's on morphine. He's on fluids, steroids. The hospitalist has correctly held his metformin and antihypertensives. His heart looks pretty good. His creatinine is at 1.2. The rest of his labs look okay. He's a little hyperglycemic. Over the course of his ICU stay, he doesn't seem to improve as quickly as the team wants. That they get a CAT scan that shows he's got a loculated empyema. He has a bilateral pneumonia, a chest tube is placed. After that, his hypoxia begins to improve. His X-ray, however, starts to develop bilateral infiltrates. He remains borderline hypotensive. By day 3, his creatinine abruptly rises. His urine output has been declining for the last 2 days. He's given several liters of fluid. The following day, his creatinine is 3.6. He's given Lasix, but really doesn't pee much. By day 5, his creatinine is 4.7. His X-ray shows worsening bilateral infiltrates. He's obtunded and placed on a ventilator. And he's now a little on the low side with his sugars. So that's, you know, for those of you who practice hospital medicine, I would imagine you've seen this type of case before. And it's kind of, we're going to come back to this, you know, every couple slides I bring you back here. And there's a lot of things here that have contributed to this patient's kidney injury, some of them preventable, some of them not, some of them that we just need to be cognizant of. All right, next slide. So, AKI, there's a lot of ways to define it. In general, you're going to look at your serum creatinine. That's going to be pretty much what you turn to. And if your creatinine, and this is just from a recent set of guidelines, your creatinine goes up by 0.3. There is some element of AKI. The other one that you commonly see is 1.5 times baseline. So if your creatinine's 1 and it ends up being 1.5, that is AKI. Or oliguria for greater than 6 hours. Again, I don't love that because, you know, that can happen for a lot of reasons. Next slide. So there is a push these days to stage AKI. As you can probably tell, I'm not a big fan of algorithms and kind of things to look at. I like to think about things a little more physiologically, but you know, there is something to be said about the more rapidly rising the serum creatinine and or oliguria, the alarm bells just need to go off. Okay, when my creatinine is going from 1 to 2 to 4 to 6, or wait, this patient hasn't made much urine in the last 12 hours, there your alarm bells really need to go off, because it is, you know, just severe AKI, which portends a poorer prognosis for the patient. Again, the way I like to think about AKI is, number one, what's the cause? Why did the patient develop AKI? And then number two, what is that etiology will in large part determine the severity and duration. And obviously I see AKI all day long, so I have a sense of that. And it's a little more challenging if you're not seeing, you know, 30 cases of AKI a week. But if somebody has a renal infarction, well, I know that AKI is going to be severe and it's going to take a very long time. If somebody gets contrast nephropathy and otherwise has normal kidneys, well, I kind of have a better time arc on that AKI. So that just comes down to some, you know, regular experience. But again, anytime you see AKI, what's the cause, and is this cause going to be severe? Next slide. And I think this is an important slide, and this is sort of, I think, the theme of this particular talk. And this is not something that, even when I was training or for several years, I never really thought about AKI this way. But I think it's important to realize that certain patients are going to be very susceptible to developing kidney injury. And kidney injury is a combination of that underlying chronic susceptibility plus an acute event or an acute insult that's thrown in over the top. And so I think if you can kind of, as you're seeing patients in the hospital environment, have that sort of sense of, this is a patient who is likely to develop AKI, it may change the way you manage them. Because you're not going to have a nephrologist on board if the patient doesn't have AKI. But I think it's like a heart patient. We think about heart risk factors a lot. Same way we should be thinking about kidney injury risk factors. And there's some key ones. And honestly, the number one thing is going to be volume status. The kidneys like volume. Okay, so when it's a function of dilution to some extent. When you have a lot of volume, your blood circulation is filled out, a lot of blood going through the kidneys, any particular insult is diluted because there's plenty of volume that's kind of protecting the glomerular flow. So as we know, most patients who end up in the hospital, aside from heart failure patients, tend to be volume depleted. So when they first arrive right into the ER, or that first day or two, they're in the hospital, they're in the ICU, they're going to tend to be in a volume depleted state. And that's exactly the time you want to be very cautious about any potential kidney toxins, contrast. Okay, is this patient a little hypotensive? That is something that may tip them over. Really tight medication management, avoiding any extraneous medications. So that's something to keep in mind. Of course, advanced age, vascular disease. So any patient with microvascular disease, they've got it in the kidneys too. The kidneys are very vascular organs. Both, there's obviously large arteries and arterioles supplying them, where you can have, large infarcts and things that happen there, or you can have microvascular changes that are happening in the smaller arterial systems. Diabetes is the most common cause of microvascular disease in the renal system. Diabetes itself, long-standing diabetes, is a risk factor for kidney injury. Any chronic comorbidities, especially cirrhosis, heart failure, these are all risk factors for developing kidney injury. And things like cirrhosis and heart failure, it kind of comes back to this volume concept issue, but on reverse. When you're hypovolemic, you're not getting enough forward flow to the kidneys. You can have prerenal azotemia or kidney injury, be susceptible to further kidney injury. In the setting of cirrhosis or in the setting of heart failure, especially systolic heart failure, it may be the opposite. The patient may be hypervolemic. They've got ascites or they've got, pitting edema, pulmonary edema. However, there's not enough forward flow to the kidneys because in a cirrhotic, there's, systemic vasodilation. In a heart failure patient, the pump is just, there's not enough cardiac output. But because there's impaired perfusion, the kidneys tend to be very susceptible for those patients, which is why you've got syndromes, hepatorenal syndrome, cardiorenal syndrome. I see here female gender. I think that's a function of just size, meaning there, the average woman tends to be slightly smaller than the average man. Toxins tend to be more accumulated. As a result, the dosing becomes a little more challenging of various things, and there's less. There's a the total glomerular filtration is slightly less, and I can't think of any other reason why that would be a susceptibility. Black race is a susceptibility only, but in large part that's related to the comorbid states. It's been stratified, but I don't think it's clearly understood. I think where there is a clear correlation is malignant hypertension and hypertensive kidney disease with the African, with Black race. And of course, underlying kidney disease. If you have underlying kidney disease, that is going to be pretty much the number one risk factor. Any questions on that slide? And then I think we'll get back to our case. And is that, just curious, is this way of thinking about a potential, about the kidney system, I should say, something that people do regularly, or is this helpful, or just curious if there's any input on that?
Very helpful.
Okay, good. Moving on. So let's kind of just get back to our case here, based on what we've, kind of learned here in the last couple slides. And so this patient, as soon as they've rolled into the emergency room, has some serious risk factors for kidney injury. He's 70 years old. He's had diabetes for 20 years, and it's severe enough that he's now on insulin. He's also come in hypoxic. And so that is also a risk factor because, the medullary system in the kidneys is very oxygen dependent. Furthermore, and this is something that's often missed, he has what's, I think aptly and conveniently termed relative hypotension. So this patient, as we see, does have hypertension. He was on antihypertensive medications. Now he's coming into the ER with a relatively normal blood pressure of 102/54, but for him, that is hypotensive. And so that becomes a risk factor for further kidney injury. So in this particular patient, as soon as he rolls into the ER, there should be some recognition that this is a patient who is susceptible to kidney injury. Okay. Okay, another same concept. There's a recurring theme throughout our talk here is that the renal insults alone. So if, a healthy 30-year-old man walks in the emergency room with a sinus headache and gets a load of contrast and someone gives him gentamicin, chances are his kidneys are probably going to be okay. Why? Is because he has no risk factors. He's otherwise healthy. He's got no comorbid states. But the majority of patients who are hospitalized don't tend to be that healthy. They have they tend to be older, they tend to have comorbid conditions. Like we mentioned, they often tend to be volume depleted. And so these are the patients who are going to be at higher risk for kidney injury. Next slide. This is kind of busy. I don't think we need to spend a whole lot of time here, especially because this is really specific to the United States. And I know we have folks from other parts of the world as well. But I think the take home message with all these bullet points is that AKI is very prevalent in the hospital environment and has become more and more prevalent over the last 2 decades. And the reasons for that are multifactorial, but part of it is that we have a aging population, but that population has done well. And so, when they do get hospitalized, the advanced age becomes a risk factor. That along with that comes comorbidities that often are risk factors for developing AKI. And so right now, AKI, it varies a little bit depending on the part of the country, but you're talking to about 5 to 7% of hospitalized patients develop kidney injury. Of those, about 5 to 10%, again, depends if you're at a tertiary care facility or a small rural hospital, require kidney replacement in the form of dialysis. Naturally, in the ICU, AKI becomes much more common. A patient who develops AKI in the hospital has a much worse prognosis at multiple levels, okay? The hospital stay number 1 increases, and it can increase it can double. So if you have a pneumonia, the average hospital stay is something like three days or 2.7 or something along those lines. If a pneumonia patient develops AKI, it goes up to about 7 days. So, in many cases, just the prolonged hospital stay leads to other nosocomial problems. And so patients with AKI have both higher morbidity and higher mortality. And this we'll touch on at the very end, people who survive AKI, which is the vast majority, often do have long-term consequences, meaning they have CKD, they can develop end-stage renal disease, very rarely, but it can happen. But that's something we'll touch on at the end. Any questions on this slide before we move on? And unfortunately, this is all United States specific. It was a little more challenging to get kind of global data. There were some one-offs here and there on various countries that I've done some work on kidney injury, but I couldn't really get anything. I think there's so much variability between countries that I couldn't really get anything outside of the United States for data. Okay. Okay, so this is it's older data from 2010, USRDS, which is a large database on kidney injury, ESRD. A lot of data has been pulled from this database over the decades. And I don't think we need to spend too much time here, except the take-home point is that patients who develop kidney injury in the hospital often have often have repercussions after leaving the hospital. Okay, number 1, we talked about prolonged hospitalization itself. Once they leave the hospital, they are much more likely to require a skilled nursing facility, an LTAC, something along those lines to continue to manage either other nosocomial problems or the kidney injury itself. And then naturally, if you end up in a longer term care facility, your outcomes also go down versus a patient who's able to go home. There's only a small number of patients that develop ESRD. So I think when you see a patient in the hospital who develops AKI, my first thing to do when I get called, and I think this maybe is could be helpful for the hospitalists out there as well, is I tell the patient right up front, don't worry about dialysis. Right now, what we're focused on is your AKI and getting you better so that you can safely get out of the hospital. But this is not in any way a sentence to lifelong dialysis, or that you're going to need dialysis for the rest of your life. And because that is immediately what most patients, that's where their mind goes, because they're so scared of that outcome of needing dialysis for their life, that's where the fear comes in. And I think it's important to understand that the vast majority of patients with AKI recover. And even those who still have kidney disease rarely require long-term dialysis. So I think that's kind of a take-home point, I believe, because you want to reassure the patients and focus on managing the AKI, which may require some dialysis in the hospital, but that doesn't necessarily correlate to long-term dialysis. Okay, next slide. Okay, so this is just a little bit of kind of a bullet point slide on some of the common things that cause AKI. Before we get here, should I take a quick pause again to see any questions on anything I've said so far?
Is obesity a problem with AKI?
I have not seen obesity as a risk factor in and of itself, as a risk factor for AKI. Where obesity is a risk factor for certain types of CKD. So there is a glomerular disease called FSGS that can lead to chronic kidney disease and proteinuria, which we see in obesity. Naturally, obesity is a risk factor for diabetes, which is then a risk factor for kidney injury and CKD. However, I did not run across obesity being an independent risk factor for AKI. Okay, so these are just some bullet points. I'll read them off, and feel free to jump in if you have any other thoughts. But you've got in the hospital setting. Well, actually, let's first look at the diagram. Going back to our training, we all know there's three types of AKI is categorized into three ways: pre-renal, intrarenal, and post-renal kidney injury. Pre-renal involves hypoperfusion, so impaired perfusion. But the renal, if you were to do a biopsy of someone with pre-renal azotemia, they should have a relatively normal appearance of their renal tissue, because there's not any intrinsic injury. This is from volume depletion, which leads to impaired perfusion, which leads to impaired clearance of creatinine, and your creatinine goes up. But once you give that patient volume, once you correct the pre-renal factors, their kidney function should quickly get better. That's just pure pre-renal azotemia. Important to keep in mind, this is just, I guess when you think of AKI, pre-renal azotemia does not always happen in isolation, okay? So a lot of times, pre-renal azotemia happens in conjunction with ATN. So youngish person, maybe they're running a marathon, okay? Maybe they're out there and they're working all day on air conditioning units and it's 100 degrees out. They're pre-renal, they get home, they take some ibuprofen because they've got a headache, suddenly they stop peeing, okay? So that patient has pre-renal azotemia, but because of that, they were very sensitive to ATN. They took something or something happened, maybe their blood pressure dropped too low from being volume depleted, and they developed ATN. So pre-renal azotemia doesn't always happen in isolation. Intrarenal issues are going to be kind of the majority of what we see in the hospital, which is going to be ATN. ATN is the most common cause of AKI in the hospital setting. And then more rarely, you can get interstitial nephritis. And even more rarely than that, you can get glomerulonephritis. And then post-renal is, it's just a plumbing problem. The pee is not going in the right direction, whether it's at the urethral level, ureteral levels, bladder level. There is a blockage in the plumbing. That blockage leads to back pressure, and various cellular things happen that basically cause the kidneys to stop producing as much urine, and you develop AKI. So those are the broad categories. Now, if you break down ATN, which ATN, acute tubular necrosis, is going to be the vast majority of what you see in the hospital environment. And there's going to be two forms of tubular necrosis: ischemic and toxic. Ischemic is going to be hemodynamically mediated, so hypotension, shock. In the case of our patient, Mr. Kidney, relative hypotension. Operative hypotension is very common, and there's a reason for that. Yeah, I'll just go through it real quick. And in the operating room, patients are heavily anesthetized. Those anesthetics impair autoregulation. So the patient on the operating table is much more sensitive to a drop or dip in blood pressure because their autoregulation is impaired because of the heavy duty anesthetics. Hypoxia, hypoglycemia, a little less rare, but prolonged and severe hypoglycemia can contribute to kidney injury. Any sort of severe vascular event where you interrupt blood flow, of course, that's a catastrophe, and that can lead to kidney injury. And sepsis. Sepsis is an independent, in addition to the shock, sepsis has independent effects on causing a kidney injury at the cellular level, from inflammatory mediators and all sorts of other things. But that can also cause ATN. And then the other big category of what we see is toxic ATN. So things that we are giving the kidney, the patient, oftentimes. Radio contrast is probably by far and away the most common. Aminoglycosides, amphotericin, colistin. There's a host of various chemotherapeutic agents, and the biggest culprit being platinum-based chemotherapy. NSAIDs, again, NSAIDs get a really bad rap. They are good pills. When my knee hurts, NSAIDs they're like magic. And so, in general, alone, without any other culprits, or in a relatively healthy patient, I'm really not that worried about NSAIDs. But in a patient who's hypoperfusing, and a patient who's hypotensive, and a patient who's cirrhotic, a patient who's also on a high dose of an ACE or ARB for kidney disease or for heart failure, those patients can be susceptible to AKI, and the NSAIDs, a day or two of them can just tip them over the edge. In the case of rhabdomyoglobin is a toxic element to the tubular system. Light chains in the case of myeloma. And then a little bit more, well, actually not rare, depending on what part of the country you're in, but toxic ingestions. There's several that can cause kidney injury as well. So that is kind of a very long list of things that cause kidney injury. Anybody have any comments on that or anything they want to add? That's not by any means an exhaustive list. I'll take a little break.
I know you were mentioning the relative hypotension, but that could be so difficult to assess for a new patient coming into the hospital. And
Yep.
So many, particularly often elderly patients, sometimes are hypertensive coming in. When you see them, they're actually normotensive, let's say they're 130s. Is that a concern? Let's say they're normally riding at the 160s and now they're in the 130s or 120s. It seems to me that is a relative hypotension, is it? Or when you're speaking of relative, is it
relative hypotension? I think that the question becomes, for that particular patient, is the degree of relative hypotension enough to cause tubular necrosis? And so I think a patient who's when the 130s, who's normally in the 150s or 160s, probably not. It is significant, but they probably have enough perfusion at that time. But that patient who, if they drop significantly more, or again, they may be, the relative hypotension alone may not cause the kidney injury, but maybe the addition of an ACE or ARB, or the addition of NSAIDs, or the addition of contrast might tip them over. But you're right. It's not, and that's why relative hypotension is a concept and not a diagnosis, because it's too hard in the sense it's clinically dependent, patient to patient, and it's not a diagnosis, but it's a clinical concept that I think it's important to keep in the forefront of your mind.
I have a question for you. Frequently, when you have a hospitalized patient, you have one reason or other to get an IV test. I'm sorry, a CT, a contrast CT, and there's various factors that go into that decision, what's safe, what's not safe. Would you comment about that? Hydrating the person ahead of time,
Sure.
nephrology consult, because it comes down to kind of weighing the pros and cons oftentimes.
Exactly. Yeah, I think the next slide gets back to our case, and we'll incorporate a little talk on contrast Oh, yeah. I'm going to skip this slide, I think. This is just when you have levels of kidney injury, what to think about. Well, actually, no, let me run through this real quick, because it does sort of relate to what we're talking to, which is pre-AKI, which you see high risk there. That's sort of what we've been discussing here, which is, hey, this patient's at high risk. Let's make sure they're not on nephrotoxic agents. Let's ensure that they have volume. Do they need, if they're in heart failure, do they need non-invasive cardiac monitoring? I know people don't use Swan-Ganz anymore, but we used to for volume monitoring. Obviously you're going to follow their creatinine, their serum output, avoiding hyperglycemia, avoiding hypoxia, and then contrast, which we'll talk about. Once they develop AKI, if it's mild, well, okay, we're going to get our workup in, check the creatinine, quantify proteinuria. I'm not really talking too much about that today, but we're going to really keep a close eye on this patient, look at their med list, clean things up, try to weather or ride out the AKI so it doesn't advance. That's probably about the time you're going to call a nephrologist if you have one available. And then once the kidney injury gets more severe, well, then you want to think about, okay, does this patient need to be in the ICU? Does this patient need dialysis? I need to go through every medication and dose it properly. That's really going to be the work of the nephrology specialist, that's going to be handling that. And then what kind of access do I need? But again, that's more nephrology specific. But sort of, again, this is another graphic representation to capture what we've been talking about. Next slide. Okay, back to our patient. So Mr. Kidney, as we know, had several risk factors: hypoxia, relative hypotension, age, diabetes, critical illness. And then as he's moved to the ICU, a CAT scan is done, and it's done with contrast to really sometimes people don't always have a reason for giving contrast, sometimes people do, but that appears to be, in our case, what really tips him over to kidney injury, severe kidney injury. Now, we also see here that he remains hypoxic, that his blood pressures are significantly lower. So if he's on antihypertensives at home, you expect his blood pressures to be, without antihypertensives, greater than 140/80. Otherwise he wouldn't be on those meds. But now he's really borderline overt hypotension. So that is a significant risk factor, in and of itself, probably enough to cause ATN. But in this case, to me, it seems like the really toxic offending agent was the contrast dye. And we're going to talk about that in a second. So here, what we see also is that when the contrast dye is given on day 1 or day 0, and then the next day or two, he's still hypotensive, he's still hypoxic, we really start to see the creatinine rise a couple days after that. So that's where, again, clinical suspicion plays the role, because the creatinine is not going to rise that quickly with most forms of kidney injury. It takes at least 24 hours, oftentimes, before you see a significant bump in serum creatinine. But what you may see is that patient, their urine output declined for the 6 hours post-contrast, or they had a hypotensive incident at 11 o'clock at night. They were put on pressors, and you look through the chart and, oh, hey, for that 6 hours, the patient didn't make any urine at all. That's when the kidney injury occurred. And that's when you have to start thinking about, okay, what do I do for volume? What do I do for medication dosing? You don't want to wait until the creatinine has already gotten away from you, because then really you've missed the kidney injury window. You're into the continuation phase of kidney injury. And just let's finish off this case. The patient at that point okay, the hospitalist comes in, the intensivist is there in the morning. Oh, wow, creatinine's way up. Let's give this guy some fluids. But the kidney injury has already happened. The tubules can't process that. It's not going to help them. So he doesn't really make much urine. The next day his creatinine is rising. Lasix is given in the hopes to, okay, can we stave off dialysis? Give this guy some heavy duty doses of Lasix to see if we can get him peeing. But really, by that point, the kidney injury is in the continuation phase. So it's just evolving and progressing. And then what you often see is that the repercussions start to kick in. Day 3, day 4, there's obviously the two big things to think about are volume in kidney injury. So the patient who has stopped making urine. I missed that, sorry. I wasn't able to understand that. Can someone help give me a hand there?
Sorry about that. I don't think that was a question. I think somebody just had their mic on.
Oh, I gotcha. Okay, no problems. All right, so where were we? Yes, so once a patient develops, especially oliguric kidney injury, volume becomes very, very important. So the patient is going to be at high risk for developing hypervolemia and pulmonary edema, which is what happens in our case. Furthermore, medication side effects begin to stack up in severe kidney injury. So our patient becomes obtunded, and there's a reason for that. The patients in the ICU, they're often getting morphine, which is cleared by the kidneys. They're often getting maybe some muscle relaxants, maybe gabapentin for if they're diabetic. There's various medications and especially narcotics and sedatives that are cleared by the kidneys. And so once you develop kidney injuries, the metabolites stack up in the system and they lead to all sorts of bad problems, especially in the ICU with altered mental status. The other big thing that you see in diabetics is that they become hypoglycemic because insulin, even low doses of sliding scale insulin stack up in the case of kidney injury and can cause hypoglycemia. So in this patient, you're seeing pretty much all the worst case scenarios of kidney injury, which is pulmonary edema, medication toxicities, hypoglycemia, and they're now attendant on a ventilator. Unfortunately, not all that far from the reality of many ICU patients with severe kidney injury. So let's stop for a second here and get back to the issue of contrast nephropathy. So in our case, we might have been able to prevent all of this had the patient not gotten a heavy dye load in the setting of being very susceptible to kidney injury. Contrast nephropathy is relatively common. And in the literature, it can be anywhere from 3 to 5% of patients who get a dye load can develop contrast nephropathy. However, serious side effects from contrast nephropathy are relatively low. So a lot of patients develop some mild kidney injury. The vast majority of them improve very quickly within a day. Sometimes you might not even pick it up. I mean, we pick up in studies, they can pick it up because they're looking at urine output very closely hour after hour. They see a bump in creatinine at hour 4. Well, we're not doing that in real life. We're not checking in until the next day oftentimes. So you might not even catch some very mild contrast nephropathy. And so in your non-critically ill patients who don't have a lot of risk factors for contrast-induced kidney injury, the benefits of this dye study may far outweigh the very low risks of developing contrast nephropathy. So, there's all sorts of reasons we need contrast or angiograms, okay, cardiac angiograms. So there's very legitimate reasons that we need to use dye for imaging or for invasive or diagnostic procedures. And in your patients who do not have a lot of risk factors with normal renal function, who are well perfused with IV fluids, and we'll get back to that in a second, the risk factors are very low. The number one thing to do for anybody with or without risk factors is to make sure they are fully volume replete prior to any major dye study, especially a diagnostic or invasive study that's going to use a high dye load. And you want to give that patient, I mean, normal saline is fine. There's been a lot of studies done with bicarb. Really, it's the volume load that is the most beneficial. And so I just go with saline and I give a lot of it. And, you want to give 2-3 liters of normal saline to the point that the patient is achieved a diuresis. So they're now at the point that they're peeing it out and they've got to go to the bathroom every 2 hours. That's kind of where you want to get to before the dye load is given. This becomes especially relevant in a patient like this who's got risk factors. So anybody with underlying CKD, creatinine is 1.6, 1.8, even 2, 2.2. The risk factors are still low if you give that patient a healthy dose of IV fluids. Now, if your creatinine is 4 or 5 and you're trying to stave off dialysis, that is not the patient you want to give a dye load, okay? But early CKD, moderate CKD with volume, risk factors are still low. Diabetic patients with proteinuria, patients with vascular disease and some CKD, again, with enough volume, the risks of contrast nephropathy go down. There is a group of patients who, in general, you always just never want to give dye to, which is going to be your cirrhotic patients, because no matter how much volume you give to a cirrhotic patient, it doesn't end up at the kidneys. That patient is systemically vasodilated from nitric oxide, systemically from all these things. So that volume is going to their belly. It's going to their, third spacing. It's not getting to the kidneys to achieve perfusion. So if it's a cirrhotic patient or a systolic heart failure patient, because, obviously you can't give that patient volume because they'll go into CHF. Those are the patients, those are subgroups of patients. You really, the reason to give contrast has to be really, really, really good and really, really important, such that the benefits of that study outweigh the high risks of contrast-induced kidney injury. So I know that was a question. Again, unfortunately, with kidney injury, there's no good answer. There's not a right or wrong. It's just a judgment, understanding the risk factors, and then asking, is the benefit in this case outweigh the risks of kidney injury?
Is bicarbonate therapy out?
I think it's as effective as saline. I don't think there's a problem giving bicarb. I just don't think it's any more effective.
Is there any role at all for mannitol anymore? Or is that just ancient history?
That's ancient history. Yeah, mannitol. There's a few drugs in the history of kidney injury that have been tried over and over. Mannitol. Oh God, what is the? Oh, I'm drawing a blank. Sorry. There's been. To put it simply, there's been so many drugs tried over and over in different permutations. There's one in particular, I'm drawing a blank, but nothing has worked for kidney injury. There is no, and that's why we don't have a drug to give. We don't have even preventive drug like coronary artery disease. You've got aspirin, you've got statins, you've got, you can give it thrombolytics if you need to. You've got interventions. We just don't have any of that for kidney injury. There are no drugs that work. Mucomyst.
What about albumin?
What's that?
Albumin.
Albumin is great. It's, again, no better, no worse than volume. I think that than saline, but the advantage of albumin is that it distributes more to the intravascular space because it's a colloid versus a crystalloid. So you don't have to give as much of it. So you can, run 50 grams of albumin into a patient in 100 and 250 cc's, and that's the equivalent of giving more than a liter of normal saline. So you've got the speed effect and you've got the instant volume expansion, but there's no inherent benefit to albumin or hetastarch or any other synthetic colloid expanders versus saline. It's just that it's more bang for your buck.
Thank you.
So we just went over a ton of information there, contrast nephropathy, and let me take a quick pause. Any questions?
In this
Why don't
situation, does a loop diuretic injure the kidneys?
Actually, I've got a slide on diuretics coming up, so we'll get back to that. And for I forgot the doctor who asked about the contrast nephropathy itself. Did that answer your question? Was that sort of?
Yes, definitely. How about one of your previous slides? You mentioned no subclavian. Would you expound on that part for me?
Oh yeah, sure. So there was an era where subclavian catheters were actually, when I was 15 years ago, 20 years ago, people were throwing in subclavian catheters like for every kidney injury patient, because it's kind of an easier catheter to place in a patient in the ICU who's or in the hospital bed, because you can just go right under the subclavian. But there's two major things. Well, A, there's a high risk of pneumothorax. B, because Mahuker or the temporary dialysis catheters are thicker, there is a risk of subclavian stenosis, and especially if that catheter is left in for days or sometimes a week or more, you can stenose the entire subclavian, which can lead to a world of pain for that patient because of vascular. Good, and it's so they're very much frowned upon, except unless it's an emergency and you need one for a day, that's probably okay. But you don't want to place that dialysis catheter there that's going to be used for dialysis for the next several days. You want to play an IJ or a femoral. A femoral has other disadvantages, but an IJ or femoral. Okay, moving on. Okay, so and I don't want to spend too much time on the management of AKI. I do want to talk a couple things. I know we don't have much time left. We'll talk about diuretics and volume status. But when you've got a patient with AKI, oliguria is pretty much, well, A, what's the cause of AKI? B, are they oliguric? A patient who's oliguric, that's a serious patient. Okay, I mean, if you stop making urine, if you have a nephrologist, make sure you call them right away. But that patient is going to have to be managed very closely. It's a poor prognostic indicator, poor outcomes. Hypervolemia can quickly become a problem. So you want to, in general, you want to try to use diuretics for your oliguric patients. So with kidney injury, and I know that always becomes a bit of a confusing spot. Like, a lot of people are trained to think, well, okay, kidney injury, give fluids. That's really okay. Give fluids, give more fluids, give another batch of fluids, which can be okay if the patient is volume depleted, or if the patient is non-oliguric and in the early phase of their AKI. That may be the right time to really load them up with fluids. However, once a patient is in the prolonged phase of kidney injury, you've already volume expanded them, fluids can become your enemy. Next slide. So, and the reason is because, of course, in the setting of kidney injury, the IV fluids can lead to third spacing, they can lead to pulmonary edema, gut edema, all sorts of problems with hypervolemia, and you can't get rid of the fluid without dialysis. So you want to be cautious once the patient has sustained kidney injury, especially if they have diminished urine output, in continuing high doses of IV fluids. The key is to use enough IV fluids when the kidney injury develops or when the patient enters the hospital to make sure they're euvolemic. And I think we've talked about a lot of this, but minimize toxic exposures. We've kind of been harping on that the whole talk here. Correct anemia, avoid hypoglycemia, avoid hypoxia, avoid relative hypotension. So that may just be making sure they're not on anything that will drop their blood pressures. Antihypertensives, fentanyl, morphine, anything that's going to drop blood pressures, take that away from the patient who's borderline hypotensive. Renally dosing medications, antibiotics, blood thinners. I kind of make a rule, and whenever I have a consult, my goal is to get rid of any medications that the patient does not absolutely need, because they accumulate in kidney injury. And loop diuretics can be your friend. Oliguric patients, all the same things, but minimize volume once the patient has stopped making urine. High dose diuretics to try and convert them and try to maybe stave off dialysis. You have to recognize that an oliguric patient those are the patients who are going to develop severe hypokalemia, problems with hyponatremia from dilution because they're not able to pee out water, problems with more severe acidosis. And those patients, all of the oliguric patients, you have to have an early threshold for dialytic intervention. Next slide.
Comment on vancomycin?
Vancomycin. So vancomycin got a bad rap for ATN from even before my era. It was constituted with the way it was constituted, there was a rash of ATN from vancomycin early on. That problem has been solved. So vancomycin rarely causes ATN, meaning it's not a tubular toxin like gentamicin or colistin or cisplatin, or you don't just give it and bang, the kidney shut down. Prolonged vancomycin can rarely cause interstitial nephritis. And then what I see is that the patients who are on protracted vancomycin, whose levels are not well managed. So a lot of patients that are LTAC or SNFs, they're on vancomycin, they have risk factors for AKI, and you go back and their vancomycin level was 50 for 2 days. Those patients do, for whatever reason, tend to develop kidney injury, some form of interstitial nephritis, more than ATN. So it is an issue, and we do like to stop it once you develop kidney injury, mainly because it's impossible to clear. I mean, without dialysis, if you give someone vancomycin, it can stay in the system forever. And so, you want to stop it and try and find alternative agents, but rarely is it the sole cause of kidney injury.
Thank you.
Okay, running out of time here. I'm wondering if let's skip this slide. Let's skip the post AKI. Well, you want me to talk about diuretics and volume, or do you want me to talk about what to think about post AKI? And neutral?
Post AKI, I think would be interesting, but
okay, let's just, because we've got actually a few minutes here, so let me just, can we go back actually one slide? Okay, so we talked about this. Patients who develop kidney injury, a very small fraction go on to need dialysis, about 2%. But a lot of patients with kidney injury go on to have continued CKD. It's often early stage, but in the USRDS studies, there was, and again, these numbers stratify based on risk factors. So if you're old, like 80 or 70 plus, if you have underlying diabetes, underlying vascular disease, those are the patients who are going to most likely have some element of CKD post-hospitalization that is going to continue. So AKI is not only an inpatient issue, it can lead to CKD and very rarely ESRD. Next slide. So I put this together here just so, for those of you who are in an office setting, of course, you hate getting that patient who's been in the hospital for, 2 weeks. They had kidney injury. They needed 3 dialysis sessions. They come out with a creatinine of 2.4. This is not a good office patient because it's going to take a long time. They're sick. You've got to handle this. So this is not exhaustive by any means, but it just sort of came to the top of my head on the things that really we all need to think about in the outpatient environment post-AKI. Number one is the med list. Okay, that patient, listen, even though ACEs and ARBs are great pills for your heart, they're great long-term for your kidneys, while the patient is recovering from AKI, don't worry about it. Leave them off. NSAIDs, of course. Antibiotics, yes, Bactrim, aminoglycosides are inpatient meds, but you want to stay away from anything toxic. You also don't want to stress about their blood pressure too much, okay? They come into the office post-hospitalization, their blood pressure is 150 over 84. Actually, that's good. I'm happy with that. They're well perfused. Their blood pressure is a little bit on the higher side. In the recovery phase of AKI, that's okay. You're going to bring that patient back every week probably. So you have the opportunity to correct their hypertension once the kidney injury has either resolved or gotten back to steady state. These are just some pills that you need to think about stopping. Sulfonylureas, because they accumulate and cause hypoglycemia. Any renally dosed antibiotics, always stop metformin in the setting of AKI or advanced CKD. All the modern or new blood thinners are all renally dosed. And we as nephrologists do see regularly a retroperitoneal bleed from Lovenox or from Xarelto. And it's called spontaneous, but it's not. It's the patient has kidney injury, the dose of the blood thinner was not adjusted, and the patient bleeds. The whole category of pills, unfortunately, that patients love, but that are not good in the setting of kidney injury are somatic relief pills. Gabapentin, Reglan, allopurinol, muscle relaxants, baclofen, cyclobenzaprine, all of those things need downward dose adjustments, or if possible, just stop them if the patient can handle it. Patients need to have chemistries regularly. If it's severe AKI, 2 times a week. You want to keep very close to that creatinine and potassium, and then weekly after that. Home blood pressure log is helpful. Volume status becomes very relevant. A patient who has got kidney injury post-hospitalization is often going to be hypervolemic, and they're going to need Lasix, and they're going to need higher doses of Lasix to help handle volume and hyperkalemia. And of course, obstructive nephropathy, Foley care, urodynamic studies, and a GU referral. Diet, patients really stress it, and family members really stress about diet. I just tell them not to. It's just, they're overloaded. There's so much going on. I just tell them, listen, don't eat fast food. Don't eat junk. Eat a balanced cardiac diet or diabetic diet, whatever you're on, and just don't even stress about it, because that is sort of the least important issue in the spectrum of AKI. Dietitians don't tend to like me a lot because I keep saying that in my talks, but that is sort of my opinion on it. And so that's just a cheat sheet, and there's all sorts of other things, medications and stuff that you need to think about, but something to think about. Last slide may be coming up, or is that it? Okay, so this may be another talk altogether. I'm happy to come back, and because I didn't realize how long this would take. But management of AKI and volume it's a big issue. It's an important issue. I don't think we'll have time today to get into it. Yeah, so more stuff on volume and diuretics. I don't know. Do I have an ending slide? Let's see. I did, again, another talk altogether on back one here, COVID and AKI, some interesting stuff, but again, that could be a whole other talk in and of itself. Okay, last summary slide. So in summary, kind of what we really focused on here are what are the risk factors for AKI and to prevent AKI and spare our patients bad morbidity, mortality, pain, suffering, and general demise. Let's prevent AKI. Detecting AKI early is really important. So having a high suspicion even before the daily creatinine marker, that may be too late. They may have had AKI for a whole 24 hours by that point. That would have been the time that they really needed the fluids. Toxins, we talked plenty about. And then the monitoring of patients of AKI in the outpatient setting, that's a high touch, high risk patient that you as primary care docs, as we as nephrologists, we're doing that patient a lot of good. We're helping them a lot by bringing them to the office and overbooking them at our lunch hour or whatever needs to be done, seeing that patient a couple times a week until they get into a steady state. And then again, this is just something to think about as you see your AKI patients. Don't worry too much about end-stage renal disease. Think more about how do I handle the AKI or the resultant CKD. So that's kind of it in a nutshell. Big topic. I know we didn't kind of get to the volume stuff, but I'm happy to do this again if you want to talk about volume and loop diuretics. Can do it anytime.
Well, I want to thank you so much for a wonderfully informative talk. I think that was excellent information, excellent talk, and so practical and useful. So I really do appreciate it. And we'd love to have you come back and talk again. It is over 9 o'clock. I want to be respectful of people's time. So but at the same time, if you're able to answer a few questions for those that are able to stick around, that'd be great. But otherwise, I want everybody to have a wonderful day or evening wherever you happen to be. Dr. Prasad, I got a quick question. Do you see any practical point to getting a fractional excretion of sodium? Because it just seems like you're going to be giving them fluid, and if they're peeing, well, you got your answer, and if not.
Yeah, that's, sorry, let me just take off that phone. I don't get it anymore. I used to. I don't know. And now that you asking me about it, I've kind of forgotten about that test. I used to get them all the time in training or when I first got out of fellowship. Now again, I'm trying to. I think as you gain experience, you think a little bit more physiologically and more, the arc of the disease process. So I don't get it anymore. There is some benefits, I think, if you're confused about, hey, this patient doesn't look really dry to me, but their creatinine is 1.6. Let me just get a urine sodium or fractional excretion of sodium to help me understand what the kidney is seeing as far as. But the problem, the real problem with that test is that people equate a low FeNA or a low urine sodium with volume depletion. That's just not true. Because there's all sorts of other things that lead to a low FeNA. A heart failure patient may be 40 pounds volume expanded and have a low FeNA because there's not enough forward flow. All the FeNA is telling you is how is the kidney sodium avid for any number of reasons. Any patient with cirrhosis has a low FeNA because they're always sodium avid. Any patient with glomerulonephritis who may be volume expanded, they are also sodium avid. It's not, and there's a variety of reasons. So the problem with the FeNA is that it needs to be interpreted. It doesn't just reflexively mean that that patient is volume contracted.
When you have a patient in the ICU, in terms of monitoring the volume, would you discuss the use of the CVP pressure, and do you ever use bedside echocardiography? How do you assess somebody's volume status?
The short answer is kind of a highly specialized field called voodoo. Where it's tough to especially in your ICU patients who have been in an ICU bed for days. It's really hard to understand, okay, their ankles may have no edema, but how do you really reliably look at their sacral edema? How do you look at their weights when you know that they're actually losing muscle weight? Maybe their weight's not changing, but they're losing muscle, so what's making that up? It's not easy. I think CVP can be helpful, but again, CVP is a little like FeNA. It doesn't always correlate to let me rephrase. A low CVP is helpful. Like if you have a CVP that's 3 or 4, it's very low. Okay, that patient needs something to expand their volume. A high CVP, again, needs to be interpreted. It doesn't necessarily, it doesn't help you that much, to put it simply. I think the advent of butterflies and bedside bedside ultrasounds are really helpful. I don't have a lot of expertise myself in them, but like if you can get a butterfly probe or bedside echo and quickly look at, do they have pulmonary edema? What's their filling pressures? That can be super helpful. But I myself, I have colleagues who are walking around with this butterfly in their pockets, and every patient just boom, boom, boom. Okay, I've got a good idea of what's going on. I don't have a lot of experience myself in that.
Well, again, thank you so much. What a wonderful talk, and would love to have you come back and talk again.
Sure, happy to do a follow-up on every nephrologist's favorite topic, which is renal tubular physiology. And we can talk a little bit about diuretics.
Excellent.
Thank you. Excellent.
All right.
Take care.
Okay, all right. Bye-bye.
Take care, everybody. Bye-bye.
Bye.